ready for burns, Dr. Greenhalgh.
I had to talk about resuscitation and basically have to show the picture of the medical center. But we're going to talk about resuscitation. We haven't figured it out yet. It's inconsistent throughout the world, and we just haven't figured out, and it doesn't really work too well in burns. And so I'm going to go over some basic concepts. Sorry for that, but ways to think about it in simple terms, and some pathophysiology about why burns have such huge resuscitation. We are the record holders. I tell the students I once gave 100 liters to somebody in 24 hours, so beat that, any of you guys. So there's been huge debate about what types of fluids to use, and so I'll talk about that. And if you really are interested in a topic, the reason we go into academics is to do research about it, so I'll talk a little bit about some research we've done. All right, now a very simple concept. If you think of the body as equal numbers or just basic numbers, think of the body as 60% water, and this is simplified, obviously, okay? Intravascularly, we have 40% is water. So inside your cells, I'm saying intracellular is all water, so 40% water. And then extracellular is 20%. And of that, 5% of the water in our bodies, as a rough estimate, is intravascular in our blood vessels, okay? Now, babies have more at 7 to 8% of their weight, okay? So we'll talk about that. Now, the other thing to remember is that water flows freely through all the compartments. So it'll go intravascular to interstitial to intercellular. However, because we have all those sodium, potassium pumps and things like that, the electrolytes are different. So the main cation intracellularly is potassium and extracellularly is sodium. You guys know that, okay? Now, what keeps the water inside our blood vessels are the proteins, such as albumin, for instance. However, the electrolytes still flow freely between the intravascular space and interstitial space. Water also flows freely, okay? So normally those proteins stay inside our blood vessels, and that's what keeps the water inside our blood vessels. However, when you have a massive burn, sepsis, trauma, that creates a capillary leak and we lose some of those proteins, and that's part of the problem. So the other concept is to develop hypotension, you need to lose a lot of that water, okay, from the intravascular space. So first of all, we compensate with vasoconstriction. We know that in order to become hypotensive, you need to lose 40% of your intravascular volume, roughly. And with trauma, they say more like 30%. So a third of your intravascular volume before you become hypotensive. And that's why you still could be in shock even though you still have a good blood pressure. So the standard treatment is 20 milliliters per kilogram bolus for someone who's hypotensive, okay? And where do we come up with that? It's basically, if you look at a 60 kilo person, their intravascular volume, again, 5% of their weight is about 3 liters. Well, we're so used to trauma, we give 1 to 2 liters to every trauma patient. Right? Why? Because it turns out that's roughly 1/3 of their intravascular volume. If you do the same for a baby, a 6 kilo baby, their intravascular volume is about 450 milliliters. Again, 20 per kilo gives you 1/3, and it gets them back up to that volume, so you may have filled up the tank to where you once were. The problem is that just catches you up. It doesn't tell you anything or doesn't help you if you have ongoing losses, like if you have sepsis, trauma, burns, whatever, okay? So, and you guys all know this, if you want to follow how they're doing after the continuing loss, put a Foley in, you want to target urine output, which is only mediocre for helping you figure out what's going on. So, if I chose somebody, Dr. Goodnight, I'd take a liter of blood out of him, okay? He's hypotensive because I took 1/3 of his intravascular volume. Well, the best thing to give back to him is 1 liter of his own blood, right? And we do all these rat experiments where trauma, they bang the hell out of him, and then they draw blood out of him, and they give the shed volume back. But that's the best thing, obviously, because it stays intravascular, okay? But trauma patients don't always follow that. They spill their blood on the floor. So you don't have their blood to give back. So the second best thing is give their blood back, okay? And I won't get into the whole, whether you give whole blood or packed red blood cells, but it's 1 liter back. Now, in theory, if you have an oncotic fluid, albumin, fresh frozen plasma, you can give 1 liter back because that protein stays intravascular. So you only need to give 1 liter back, okay? Now, you know, it costs a lot to give albumin or fresh frozen plasma, and you have risks of infections and things like that. So you can give them an isotonic fluids like lactated ringers, plasma light, or whatever. And the problem is that since there's no protein in that, the electrolytes and water leaks out, so you have to give like 3 to 4 liters to make up for that 1 liter I took out of Dr. Goodnight, okay? But most of the time, we can tolerate that. Now, if you're really bold, you can give them D5W. Now, the D5 is consumed by the cells, so it's like giving free water. But that water diffuses throughout all of the water spaces, intravascular, interstitial, and intracellular, so you have to give like 12 liters, and when their sodium goes down to 115, they seize and all that. So you don't ever do that, okay? All right. Now, this is what I tell the residents, okay? If you look at the body, it's a picture of the body. So the bucket is your intravascular space, okay? And then you have water, nutrients go back and forth, waste goes back. And that's, you take a little water in and take a little water out. If you drink too much, you pee it out, stuff like that, okay? All right. Now, what happens with burn shock, sepsis, peritonitis, pancreatitis, whatever itis you want, is you get holes in the bucket, okay? And you lose water, proteins, and electrolytes. The only thing you retain really are the red blood cells, and that's why our patients' hematocrits are 60 the next day, because it's not because you created red blood cells, but it's because you hemoconcentrated that fluid. And what the body does to compensate is it makes the bucket smaller, vasoconstricts, okay, to the point you run out of fluid. And unfortunately, I've seen some people with big burns die. They're wide awake till the very end, and then they fall asleep and they never wake up. So, because they try to maintain perfusion of the brain and the heart, okay? So the goal of resuscitation is quite simple, and this is how you think about it. You pour the water in, whatever fluid you want, fast enough to keep up with that leak, okay? And the best indicator to follow is urine output. It's not that good, but that's the goal. Now, the problem we have with burn resuscitation, at least, is that, you know, if they're peeing 30 an hour, well, if they're peeing 150 hours, that's 5 times better. But the problem is if you give too much fluid, it all spills in the interstitial space. You get complications of edema, compartment syndromes. That causes problems too, okay? So the goal right now is to do urine output. All right. So our strategy is to use simple formulas to start. Now, we all know the Parkland Formula. I won't go over that. Parkland Formula is based on using lactated ringers. And for some reason, they think there's a physiologic clock at 8 hours that says you need half. Forget that half thing, because we don't do that, okay? We just base it on urine output based on that concept. Keep the bucket just as full to keep the kidneys happy. All right. Well, we know more about what causes the problem, okay? Injury causes release of local mediators, histamines, leukotrienes, whatever. There's actually so many of them that you can't think of them all. That causes increased permeability. And as I said, if you look at the burn, proteins leak out also in addition to water. There's electrolytes leak out, and it peaks about 8 hours and can persist for 48 hours at the site of the burn injury itself. Now, the concepts of what happens at the cellular level are pretty well known too. So if you look at, this is a representation of endothelial cells and the 3 kinds of adhesion molecules that hold the cells together. So there's a tight junction, which you can't really change too much, and the gap junction on the bottom is really for communication between the cells. But where the action occurs is at the adherence junction, and they know all these proteins. I won't test you on it later, but we do know the proteins and the mechanisms that occur, and especially at the VE cadherin, which is kind of interesting, is that you can see that they cross over here and they bind to each other. And if you look at the molecule, actually part of the molecule actually crosses over and they grab onto the other molecule, and that's how they hold the endothelial cells together. And if you want to get fancy, they know all the proteins that are involved. And the interesting thing is that they're hooked up to actin and myosin, and that's involved in kind of regulating the process. And these are just like muscles. The actin and myosin act like muscles in the endothelial cells. And even more complicated, they're signaling that detects shear stress, and so our vascular surgeons know all about this. And the tension that's created between the cells actually gets signaled down to the parasites, and that causes release of nitric oxide or other signaling molecules that cause vasodilation, vasoconstriction. So they know the signaling involved. And normally, between the endothelial cells, they have specific receptors that not much happens. However, if you get release of factors from your injury, such as thrombin, histamine, all those things that are involved with the burn response, those signals go on and initiate a process with the Rho signaling pathway that causes those muscle fibers to pull open the cells. So it's pretty impressive what the physiology has been learned, and they actually looked at structure. I won't worry about that. And it's really involved with that Rho pathway, GTP signaling, so we do know a lot about it. And so maybe we could figure out how to control it and prevent some of that process. Sorry, it's more physiology. Starling's curve's involved with the whole process of permeability and capillary leak too. And it's basically how much hydrostatic pressure inside and outside versus oncotic pressure inside and outside. So, and it turns out the sigma, this is the reflection coefficient, what really affects how much capillary leak is occurring. And in the process, basically, it involves how, we're going to talk about some of the oncotic pressures. So if you have more protein inside the blood vessel, you retain more fluid inside, and that's one of the debates we have in resuscitation. But it's even more complicated than that, that the endothelial cells are lined with this glycocalyx. So there's these basically carbohydrate protein structures inside the blood vessels that affect how the permeability occurs. So it's more complicated than just simply having a permeable membrane. And these actually kind of act as a sink for proteins and retain them inside. So that also affects how much capillary leak you have. And when you have sepsis, burns, trauma, that glycocalyx gets damaged at the site. That increases your permeability. And so people even talked about a new Starling curve using the glycocalyx, basically oncotic pressure instead of the interstitial oncotic pressure. And so the old way used to be that it leaked between the cells, and there's actually processes inside the cells, but the glycocalyx is involved, so that kind of keeps things inside. It goes through the cells also, and then between the endothelial cells and the parasites, there's also involvement with the whole interstitial fluid leak, so it's become a lot more complicated. So glycocalyx is involved through the cells, and they even know it through transport systems. We talked about the adherence junctions. Clathrin-coated pits are involved, so all these things go in through the cells. But it's also how much leak you have depends on how much you resorb. So the lymphatics are really important too. So a lot of times the lymphatic flow gets really increased. And what happens with burns, you damage lymphatics, you don't resorb a lot of that fluid as fast. So it's becoming even more complicated. So what inhibits lymph flow? Burn injury, but then if you have compartment syndromes, that screws it up. If you put someone on a ventilator, that increased intrathoracic pressure interferes the flow back into the chest through the thoracic duct. So those things mess up what goes on. That's why a lot of our patients with sepsis have that anasarca till you get the high pressures in the chest down. You don't get rid of it. So those are some of the other factors. All right, now back to burns. We don't have a standard formula. Probably Parkland Formula is the most common one known. This debate of crystalloid versus colloid has been going on. I've only been doing, I'm a PGY 38 now, and it's been still going on. No one's resolved it. I'm not quite as high as Dr. Goodnight, but I'm getting there. We've talked about isotonic, hypertonic. People tried those studies. The big problem for burns is what we call fluid creep. We give too much fluid. That's the problem. They look like toads, and the 100 liters I gave was probably too much back then, but he survived. Anyways, we don't have good endpoints. We don't know when you're really resuscitated. The urine output's pretty poor. But the studies also show that if you use all those fancy devices, Swan-Ganz catheters, Vigileos, or whatever, they tend to over-resuscitate. If you try to look at CVP on a burn patient during resuscitation, you can't get it above 5 because it leaks out so fast. If you look at lactate, hematocrit, those also are pretty inaccurate. So we just don't know. And some of the concepts, for instance, permissive hypovolemia, we're not sure. And then you have M&Ms talking about you didn't give enough fluids, then you have dead gut, so it's not clear. So it's clear that if you don't give enough, they die, or they go into renal failure, or since you vasoconstrict the wound, the burn gets deeper, okay? So that's not good. But if you give too much, we get compartment syndromes, abdominal compartment syndrome, ARDS, cardiac failure, all sorts of stuff. Even our babies end up with cardiomyopathies after a while. All right, so why is there a problem? First of all, I hate to tell you this, you young guys, because I'll tell you, all right, make sure you check the urine output, keep a close eye on them, and then call your intern and say, how's it going? I don't know, I haven't heard a call from the nurse yet. So, well, maybe you should go see the patient, that you have a better idea, because I'll come in the morning, they're peeing 200 an hour at 5 liters an hour of fluid. So people don't pay attention, so you gotta make sure you pay attention. The other issue, at least in theory, is that your oncotic pressure gets so low. Our albumin is pretty typically, if you check them in a burn patient, it gets down to 0.7, 0.6. It gets so low that you know you're not keeping that water inside the blood vessels. Urines aren't good. And the other thing is we call it opioid creep. What happens if you get opioids? You vasodilate, increases fluids. If you put them on a ventilator, that intrathoracic pressure decreases venous return, so you got to give more fluid. So they need more fluid. So we have not a good answer yet. So how do you get better response to urine output? Pay attention. And actually the people in Galveston are working on a computer base. They're going to say, I'm going to bypass people. We're going to put they have a computer that measures urine output and adjusts the IV fluids based on what comes out of the patient. And there's grants to support that. Now, these are some of the options we've had for burns. I'll just mention this so people still do this. High-dose vitamin C was shown by a guy named Tanaka in Japan, and it's being used by some people. We tried it here. We're talking high-dose vitamin C, 66 milligrams per kilogram per hour. It's a lot of vitamin C. They look like carrots at the end. But anyways, well, it turns out that does reduce your fluids. Now, I tried it in one of our 90%ers and took him to the OR the next day, and as soon as they gave him anesthesia, it dropped his pressure to 35. Systolic because it's an osmotic diuretic. And so in Sohm and Sen wrote a paper, again, research is good, showing that we had increased renal failure, so we stopped doing it. And maybe we need a prospective trial. All right, now I'm going to get into the crystalloid versus colloid thing. It's been going on forever. And it goes back and forth. You know, when they first did the studies, they used colloid, and then later on it's like, no, albumin's bad, so just crystalloid. So LR is part of the Parkland formula. Now the Parkland formula, however, if you look at the second 24 hours, they do say give albumin. The Brook formula says some albumin. But the thing about crystalloids is that you can get by for most people. It's just the massive burns that have the problem. Now, when you ask burn guys, a lot of them are given colloid, and that's kind of what's going to go on. And so we need to figure this out. And it's why we do research in it. All right, so what's the problems with crystalloid? You need that more fluid. It goes everywhere in the extracellular space. So you need to give like 3 times as much. So we know that's going to cause more fluid to go in, okay? And it may be contributing to that fluid creep problem we have. Now the good thing is that it works most of the time. You get by with it most of the time because that's why we have kidneys. So you pee more. And that's why at post-op day, post-burn day 5, our patients pee like crazy because they're getting rid of all that extra fluid. It's pretty low risk. And it's cheaper, and it's easy to carry into the field. So we work with the Department of Defense, so it works pretty well. So most of the time you can get by. So every small burn, you don't need to give a narcotic fluid. Who cares? You're going to do fine. The problems with colloid are they're expensive, and your risk of infections and things like that. And the theory was is if the protein leaks out, one of the proteins outside the intravascular space, it's going to suck water out, so it's got to be bad for you. And animal studies supported that process. Well, it turns out at the unburned sites, the capillary leak for protein closes fairly quickly, okay? So maybe it's not a big problem after 6 to 12 hours. And when you have an albumin of 0.5 or 0.6, you still have a big capillary leak just from the narcotic problems. All right. Now, the good thing is that once you close that capillary leak, it stays intravascular, so you need less fluid, okay? So maybe at 6 to 12 hours might be worthwhile. In our experience, it seems to help, and I'll show you some studies for that. Okay. So what are your colloid choices? Now, first of all, Dr. Heimbach used to say to me, there is no hydroxyethyl starch deficiency in anybody, okay? And Palmieri gets really pissed if you even mention the name. Her blood pressure just went up. So there are good multi-center trials, not in burns, but in sepsis and critical care patients that show it increases coagulopathy, increases renal failure. So sugars should be used for candy and not for resuscitation. Gelatins and dextrans, I haven't heard anything about those. We don't use those anymore. All right. There are people who use fresh frozen plasma for studies. There are 2 formulas. One's the Haifa formula, that's from Israel, and there's one, the Slater formula from West Penn in Pennsylvania. Seems to work, but you know, fresh frozen plasma is pretty expensive. There's risk for trolley transfusions related associated lung injury, whatever, acute lung injury. And then we'll talk about albumin. And that's kind of the big debate right now for us. In theory, it should improve oncotic pressures, slow the leak. There are even studies that say it protects that glycocalyx. So we don't know. So studies. People have done studies. Now, in 1998, there's the Cochrane Collaborative said albumin kills people, okay? So don't use it. And this is the results of that study, okay? Endotracheal tubes kill people because people who have an endotracheal tube have a higher mortality than those that don't, like you guys probably. Anyways, however, more recent data suggests if you look at another Cochrane study, no difference, okay? Basically, relative risk ratio of 1.01. So maybe it doesn't work, and these are from multiple studies. There are prospective trials that look at albumin. The SAFE trial, almost 7,000 patients. Now notice that these are not burn patients. These are ICU patients. Again, no increased risk for death. Another trial, the EARS study, risk of death reduced with albumin potentially. We don't know. It's, again, a meta-analysis. And then if you look at burns, there's 2 philosophies. Number one, use it right from the beginning. You get albumin right from the start. And the other one's to use it as a rescue. All right, we're really kind of getting too much fluid. Let's add albumin later on. So we'll talk about that. So here are some studies. 1975, 2.3% albumin versus LR. Albumin required less fluid. Another study, Jolenko. Again, these are in the 70s because these questions, they also use hypertonic saline, which is another story. And in trauma, it shows a nice study from Eileen Bulger. Early hypertonic saline did not make a difference. But they showed reduced fluids with hypertonic and reduced even more with albumin. Then Cleon Goodwin, who looked at LR versus LR plus albumin, he showed reduced fluid again. However, he found, wow, there's increased albumin in the lungs, so maybe it's bad for your lungs, so we're not sure. He did show improved cardiac function also. And this is just a graph showing that increased water, so maybe you're leaking albumin into the lungs, creating more problems for the lungs. We don't know. All right. Then the other one for immediate use, LR here, no difference. Well, what about rescue? And that seems to make more sense, okay? The concept is, you know, those capillary leaks close after about 6 hours. Maybe you should give it after about 6 hours. And we also talked about this. You drop very low. Oncotic pressure should help. So let's see what happens. So the guys at Utah did a lot of these studies. Again, this is from Amalia Cochran, 2007. Looked back at her patients, and she compared those. Now, they had a protocol that if you got way above the target Parkland rate, you would start albumin to see what happens. So they retrospectively looked at what was going on, and their albumin group was found to be more severe, more inhalation, higher lactates, longer resuscitation, higher volumes. And what they found when they added it, there's no difference in mortality, and maybe it was protective. So maybe albumin should be used. And then this is from our Army colleagues in San Antonio who looked at their protocol for bringing soldiers back from Iraq and Iran. And they had a protocol that if you did not do well about 12 to 18 hours, they would give albumin, and if there's hypotension, give vasopressin. And their protocol for the Army guys, they had reduced the abdominal compartment syndrome and mortality, so maybe it seemed to help. Another study, a little bit more difficult to interpret, really showed maybe a reduced compartment syndromes and renal failure. And then the Utah guys, again, they did in adults. They said, all right, let's look at what happens if you go above a target urine output, target fluid rate, so you're above the 4 milliliters per kilogram per percent burn that the Parkland formula says, we'll add albumin, a combination of 5% albumin and LR. So, and this is the best way to look at it. This is the group getting the LR getting out of whack. They give albumin, boom, comes down. And they look at the ratio of fluids, and it comes down. So that's pretty convincing. They also looked at what happens in kids, and they found a similar thing was that, well, it's, you know, there's a lot of data if you look at it that way, but if you look at the ratio, it seems to help later on. So maybe we should be giving albumin later on. So Park also did this from Michigan and showed that it seemed like if you add albumin after 12 hours, again, vasopressin seems to be the popular one, seemed to help out. And what they found is improved mortality, vent days, P-to-F ratio, pneumonia, abdominal compartment syndromes, and vasopressor use. So maybe albumin is something we should be using. So now there's been meta-analysis. So the people are studying this, and it's Navikas actually co-authored with this guy. Meta-analysis of all these studies, no difference in mortality. It reduced compartment syndromes, and there were no differences in respiratory complications. And renal dysfunction, still no difference by meta-analysis. Another one by Algiak, and he showed no difference in mortality, but also reduced fluid volumes. And this was challenged by an editorial and said that if you use this other study, maybe it increased mortality, so we're not sure. So that's where we are. So I actually did a survey a few years ago and said, all right, what are you guys really doing? So if you're interested in a topic, you should study it, okay? And then if you study it, you should write it up. So I did. And what we found was that people still preferred using the Parkland formula. They still used LR, but most burn surgeons cheat and add some albumin later on. Some use it right from the start, but you can see half of the people always would add albumin at some point during the case. And some use FFP. Usually they start off with LR. Okay. And we had state of science meeting headed by Dr. Palmieri, and we said, all right, maybe we should look at albumin. So that led to us doing a grant proposal to the Department of Defense, the Acute Burn Resuscitation Prospective Multicenter Observational Trial. We submitted a grant for a prospective trial, and they said, we want you to do an observational first. So that's what we're doing now. We got $2 million to the Department of Defense. They're the only ones who really supply funds for prospective randomized trauma or burn trials. Can't get them through NIGMS. So we've been doing that, and we have these 21 centers around the country. And so the idea is to look at what the practices are. We actually have 21 centers, and see what they really did, okay? And what they did was for 48 hours, they have to document every little bit of information about resuscitation. Then we look at outcomes. So it's pretty simple. We actually had 43 centers who are interested. These are the aims: look at resuscitation of albumin, how much related to crystalloid, did it reduce fluids? And we wanted to use it to design the prospective randomized trial. And the hypothesis is here. I mean, we think early albumin or sometime albumin should reduce your fluid requirements and reduce fluid-related complications. And so we had 43 centers interested. It was good to get good interest. Here's the inclusion criteria. You have to be greater than 18, greater than 20%, admitted to burn centers less than 12 hours. Now, you need to do it early if you're going to study it. And there's exclusion. So far, we have 185 patients enrolled. I can't tell you the results yet. However, what we are doing is yesterday I submitted a grant for the prospective trial because they actually sent out an email saying, anyone wants an extension of grants, why don't you apply? So I said, well, we'll apply. And we sent an RFA and another letter of request, and they said, sure, go ahead. So we'll see, $4 million grant. We'll see if we can find out. Because I think at some point, a new formula needs to be developed, and I think it's going to include some kind of oncotic fluid like albumin. So we'll see what happens. So I'll let you guys go early. I like this quote from some guy named Louis Pasteur, nature's best doctor. She cures 3 out of 4 illnesses, and she never speaks ill of her colleagues, which is an interesting way. And then, you know, Albert Einstein said this: you can't solve problems by thinking. Using the same kind of thing we used when we created them. So hopefully we'll be able to figure out the results. And these are my co-workers for these grants. Rob Curtado in Toronto, and Katrina and Mary Beth are over there, and Sandy Taylor is our statistician, and we have an ABA coordinator. So the ABA, American Burn Association, sponsors these studies. So again, take a concept, develop it in your career, and try to submit grants and try to write papers, and maybe you can solve the problem. So that's it. I'm happy to answer any questions. Dr. Rath.
That was fun, Dave.
Ah.
I have 2 questions.
Yep.
One is, we found in the lab, in our sheet, that nitric oxide really alters the lymphatic response acutely to give time for the ramp up of those proteins necessary to cause lymphatic dilation at, before 24 hours or so. So are there any studies looking at nitric oxide lung water at all?
Nitric oxide was the molecule of the year in 1998 or something like that. I'm sure they have. And there's certainly nitric oxide is very interesting. There's 3 enzymes that induce it, and I'm not sure if they've looked at the water accumulation. I imagine some people have. Nitric oxide, as you know, is the vasodilator. That's where all our nitrates actually work and stuff. I imagine they would, but it's interesting that the lymphatic components are real important, because if you look at when you resuscitate somebody, you may be giving them all this fluid, and probably a third of it's being resorbed just as fast to the lymphatics. And that's also, if you can induce that, it might prevent a lot of the compartment problems that we have. So
that's why I asked. The other question is sort of along those lines, which is we use a lot of ultrafiltration of pediatrics on bypass, and actually as soon as we're off bypass, and we've seen reduced lung water and tissue water, and bypass is an inflammatory response. So I wondered if there have been any trials looking at ultrafiltration and
So there is actually a trial called the Rescue Trial. It's basically being done by our colleagues in San Antonio, the Army guys, to look at using plasmapheresis, or CRRT actually, basically, to remove cytokines to improve sepsis response. My old boss in 1980s showed that in burn resuscitation, if you put them on plasmapheresis or even do a exchange transfusion in babies, that you could reduce the fluids. And it's a lot of work. Now, part of the problem is that you need to have buy-in by the people who do those procedures. And the Army guys do their own CRRT, so they just hook them back up. I could get a nephrologist to take someone whose creatinine is like 6 and even dialyze them, so it's hard. The Seattle guys are also doing plasmapheresis and burn resuscitation, so it does help. It's a fair amount of work, and I'm not sure. I mean, it's hard to get someone to do that. If we could just hook it up ourselves, it'd be great, because I think it does make a difference. You get rid of a lot of those mediators that cause the vasodilation and increased permeability. But yeah, the rescue trial has, it's about completed, right? So I'm not sure if I've seen the results yet, but it makes sense. The sepsis makes sense in this basically capillary leak syndrome. Dr. Palmieri.
Dr. Greenhalgh, great presentation as always. Your Einstein quote strikes me. You know, we've been measuring urine output. That's the problem that we've been addressing. And but do you think that we need to change our thinking in how we monitor resuscitation?
Well, I agree. And if we could do something better than urine output, yeah, but no one's found it yet. You know, the problem is, you know, all our non-invasive cardiac output stuff, all our swans and all that stuff, haven't seemed to make a difference. You know, we're looking for potential markers that might help, but they're pretty slow in responding, and we haven't made much progress. I mean, the urine output's what Charlie Baxter invented the Parkland Formula in 1967 or so. We haven't changed that at all. We still use urine output for trauma and everything else, and we try to use some of these other markers, but they, you know, I haven't seen anything that's any better than basic good old urine output. And especially if someone pays attention to urine output and adjusts their fluids, as opposed to just ignores it and come in the next day and they're peeing 200-300 an hour and still going at 1,500 an hour in resuscitation. But I don't know. We'll see. Hopefully. Dr. Goodnight.
David, as I age, I'm haunted by the statistics I've seen both you and Tina present of size of burn plus age, and you pretty quickly cut over the hill. So each year I can tolerate a smaller burn. So,
yeah. You and me both.
So it raises the question of criteria for entry into your drug trial, or basically taking all comers.
We're taking all comers greater than 18. So we won't take people with renal failure and liver failure, but older people too. Now, it turns out that you need more fluid when you're younger, because babies, especially proportionally, have more water. I mean, my grandmother, when she was 95, she'd have a cup of tea, her Manhattan at night, and take her Lasix. I don't know where the water came from. So old people don't need very much water, because we're giving them diuretics all the time. So it's, for some reason, maybe their intracellular water is decreased because water suddenly absorbs somewhere. But it's good to know. I mean, the concept is more the ratio of oncotic versus crystalloid and whether that makes a difference. And just like you, older people are becoming more physiologically fit. You know, my mother, when she turned 85, said, you know, this is the new 60s, you know, so they get older, that they're more physiologically sound. And when I was a fellow in the 80s, Dr. Heimbach said, you know, if you're 65 and you have 60% burn, there's no way, just let them go. But now we're grafting these people early and they're getting out. Older people, they walk the tightrope, you know, if they stay on it and don't fall off and do something like get a pneumonia, UTI or something, they make it, they fall off, they can't recover. And so it's a failed recovery or failed rescue kind of thing. That's where they have the real problem. metabolically. And people are trying to figure out the metabolic deficiency older people have and why their mitochondria don't work as well and things like that. But yeah. All right. Thank you, guys.